So I'm going to talk about the neck sparing, tissue sparing, hip stem, some intraoperative assessment issues. It has been a learning experience for me. Is this thing sending a signal to you? Okay, let's try it. There you go. You know, I started doing this total hips in practice in '85. I started out with the SROM. Tim and I started that a long time ago, but I had some problems with my type C bone, and I had to do some augmentation for those, and I moved to the Karai. But I missed the modularity, and I missed my ability to control anteversion. And so in 2005, I started using these modular designs, the Apex Modular as a SROM type of replacement, and the K2 as a tapered stem type of replacement in my type C bone. And this year in March, I started doing the ARC stem. This is a repeat slide. It's it's a curved neck sparing stem. And as opposed to one that's sort of a taper fit stem. With respect to tissue sparing approaches, I'm not interested in wearing lead, using special tables, not seeing what I'm doing, damaging muscle, malpositioning implants, learning a new set of complications, and exposing my patients to a steep learning curve. So I'll let others do that, and I'll follow along. My head resurfacing experience is limited to the shoulder. That's Dr. Steffi, my former partner, who, in addition to all this spine work, we were doing cup resurfacing on the shoulder back, and we presented that our first series in 1983, actually. That's his sugaring house where he makes maple syrup. My intent is to preserve both soft and hard tissue, and there's a resurfacing exposure there versus a neck sparing exposure. That's Dr. Keggie's work. With respect to this, it has made me a better hip surgeon relative to the acetabulum. I mean, I'm concerned about impingement, and as such, I'm probably paying more attention to what's going on with the acetabulum. And it's important to increase stability, not to compromise your acetabulum. In other words, if you've got a small woman, don't ream up to the neck size just so you can get a 32 head in or a 36 head in. So don't ream away bone so you can put a bigger size socket in there and get you up to the next diameter head. You may need to choose different bearing surfaces to accommodate the small acetabulum. So don't overream. Large head diameters are not a substitute to proper acetabular placement, and this is a typical problem with some small women. Dr. Rubash came and visited us, and he talked about the issues with respect to acetabular placement at Harvard. Only about, look at all the hip surgeons at Harvard. As far as a sweet spot relative to abduction and anteversion, they were only in the sweet spot about 35% of the time. We were lucky enough to have him visit us to see the ARC stem in the operating room after his lecture. Navigation may have a role, and you certainly do increase your accuracy with the use of navigation. We looked at the issue with respect to impingement, doing just a simple, quick and dirty sawbone study with the aid of navigation to look at a various combination of head diameters, neck lengths, and different style acetabular components, using navigation to look at our range of motion. And when we encountered impingement, here's impingement, inflection, and adduction, and posterior impingement with full extension and external rotation. With respect to our choice of bearing surfaces, we have another consideration now, and I don't know if you guys are going through this in your office, but every other patient asks me, do I have one of those recalled hips in? Well, unfortunately, in my case, I put in about 75 ASRs, and they're looking pretty good at this point in time. But it is a hassle, and it screws up your office day. So I still use some metal-on-metal implants by a different manufacturer. Dual mobility cups may represent an option in giving us the stability in the small acetabular dimension patient. With respect to the surgical technique of, not to be redundant, but you're looking at the, again, looking at the line associated with the osteophytes, make your neck resection. I think it's a little bit steeper than you typically would, and then you're just preparing the medial calcar. With respect to templating, you're looking to fit the neck. You're not looking to fit the metaphysis or diaphysis. So don't pay any attention to what's going on in this region. Okay, you're looking at the neck. Okay, so this is an oversized templating here. If you want to get a good view of the medial calcar, internally rotate the hip if you can, about 20 degrees. It's a simple set of instruments. I use a posterior approach. My incision's about as wide as my hand is, and don't need any special retractors or anything like that. So straightforward posterior approach. I do the femur first, and that's a departure from me. But it's just looking at, once you get your femur prepared, you can then assess your femoral anteversion. You know, do you have 5 degrees of anteversion? Do you have 20 degrees of anteversion? And then based on that, you can look at your acetabular placement, because relative to stability, anteversion is additive. So I think doing the femur first is valuable. Here's John's, the anterior approach osteotomy. The other thing I do is look at the head and look at the osteophytes, and we'll talk about those later, but it's important to resect the remaining neck osteophytes if they've grown down the neck some. And then I turn the head over, and I take my trial stem and I place it across the cross section of the head, and I should say the neck, and get a guesstimate of what size implant I may be putting in here. So it gives me a cross section and one saw breadth removed from the cross section I'm working with on the neck. I use a curved curette to find my canal on the chicken, and I use a curved curette and then follow that with the rat-tailed rasp. There's a Dirty Johnny joke associated with the rat tail, but so once we've identified it with the curette and the rat-tailed rasp, and then the Mueller rasp, which is really a nice device. It's got the right amount of aggressive teeth to it, and then you can check your neck cut with that if it's accurate or not. You can make a small adjustment if you need to, just for aesthetic purposes. And then followed by the implant-specific rasps. And my goal is if I get a rasp in and I can get it to such that the conical flare is flush with the bone, I could probably go up to the next size. Okay, because I want to hang that conical flare on that cortical rim. I don't want to allow it to countersink. I want to hang that conical flare up on the cortical rim. Here's just going up to the next progressive size. There's what the neck looks like once you've got it prepared. And now the stem goes in. And the T-back on the stem is about 1 millimeter, and you're back here in this cortical bone. So if you're trying to make a decision about whether you should go up to the next size rasp or not, use a trial. And if the trial's tight, stop. Okay, if you go out, because you move up incrementally. The T-back gives you another millimeter. The Porco gives you another millimeter on top of that. So if you can get if you're making a decision about whether to go up to the next size rasp, before you go there, put a trial in and see what it feels like.